Welcome to Critical Care Simplified. Today, we're building essential skills for new ICU nurses, how to understand, recognize, manage, and communicate about acute coagulopathies in critically ill patients. In the ICU, every second counts when a patient's blood cannot clot or when clotting becomes uncontrolled. Your ability to recognize these emergencies early can mean the difference between rapid stabilization and life-threatening deterioration. Let's start with normal hemostasis. Hemostasis is the body's process for stopping bleeding while keeping blood moving through the vessels. It begins with vasoconstriction, then platelets adhere and form a temporary plug. Clotting factors then work through a cascade to convert fibrinogen into fibrin, creating a stable clot. Later, fibrinolysis breaks down the clot after healing, so the vessel stays open. 4 key terms matter. Platelets are small blood cells that stick together at injury sites. Clotting factors are plasma proteins that activate in sequence. Hemostasis is the whole bleeding control process. Fibrinolysis is clot breakdown and cleanup. The coagulation cascade has intrinsic and extrinsic pathways. Both feed into a common pathway where fibrinogen becomes fibrin. For bedside nursing practice, the important point is this. When the cascade is disrupted, the patient may bleed, clot, or both at the same time. The first major ICU coagulopathy is DIC, disseminated intravascular coagulation. DIC is a severe, life-threatening disorder where widespread clotting and bleeding occur simultaneously. It's often triggered by sepsis, trauma, major surgery, obstetric complications, or severe illness. The body's clotting system becomes overactivated, forming microclots throughout the circulation. As platelets and clotting factors are consumed, the patient also becomes dangerously prone to bleeding. The second is massive transfusion-related coagulopathy. This can develop when large volumes of blood products are transfused rapidly, especially in trauma, gastrointestinal bleeding, or complex surgery. Rapid transfusion can dilute platelets and clotting factors and can disrupt calcium and temperature balance. The result is a patient who may still be bleeding even while receiving blood. The third is anticoagulant-induced bleeding. Medications such as heparin, warfarin, and direct oral anticoagulants interfere with clotting. When dosing is excessive or when renal or liver dysfunction reduces drug clearance, the balance can tip toward dangerous bleeding. Now let's move to recognition. At the bedside, look for signs of bleeding, petechiae, ecchymosis, oozing from IV lines or surgical sites, hematuria, gastrointestinal bleeding, sudden drops in hemoglobin, or new confusion that may suggest internal bleeding. Also, watch for signs of clotting, limb swelling, pain, cyanosis, cool extremities, decreased pulses, sudden shortness of breath, and chest pain may indicate deep vein thrombosis, pulmonary embolism, or impaired perfusion. Red flags require immediate action. Persistent oozing from IV sites or wounds is a classic sign of impaired coagulation. A sudden drop in hemoglobin may mean acute blood loss even without visible bleeding. Unexplained bruising can signal an underlying coagulopathy. New confusion can be a subtle warning of bleeding or clotting affecting cerebral circulation. Laboratory assessment helps confirm what you see. PT and INR assess the extrinsic pathway. Normal PT is about 11 to 13.5 seconds, and normal INR is 0.8 to 1.2. Prolonged PT or a rising INR may suggest liver dysfunction, vitamin K deficiency, anticoagulant effect, DIC, or excessive anticoagulation. aPTT evaluates the intrinsic and common pathways. A normal aPTT is about 25 to 35 seconds. It may be prolonged with heparin therapy, factor deficiencies, or DIC. platelet count is normally 150,000 to 400,000 per microliter. Low platelets are common in sepsis, DIC, and after massive transfusion. A rapid platelet drop is an early warning sign. Fibrinogen is normally 200 to 400 milligrams per deciliter. Low fibrinogen can occur in DIC, massive bleeding, or advanced liver disease. Critically low fibrinogen may require replacement therapy. D-dimer is a breakdown product of fibrin clots. An elevated D-dimer suggests increased clot formation and breakdown as seen in DIC, sepsis, or thromboembolism. It is sensitive but not specific, so always interpret it with the patient's clinical picture and other labs. A classic DIC lab pattern is prolonged PT and aPTT, low platelets, low fibrinogen, and elevated D-dimer. When this pattern appears with bleeding, sepsis, trauma, or severe illness, escalate quickly. A practical assessment sequence is recognize clinical signs with a focused head-to-toe assessment, obtain and interpret PT, INR, aPTT, platelets, fibrinogen, and D-dimer, connect findings with history, medications, and risk factors, notify the team, and act with confidence. Now let's discuss initial management. The first pillar is prioritizing interventions. Start with airway, breathing, and circulation. Stop active bleeding whenever possible. Apply direct pressure, elevate affected limbs if appropriate, and use hemostatic dressings according to protocol. Establish large bore IV access, draw coagulation labs, mobilize resources, and notify the provider with a clear report. The second pillar is administering blood products and reversal agents safely. Red blood cells restore oxygen carrying capacity. Check compatibility and monitor for transfusion reactions. Platelets are used for thrombocytopenia or platelet dysfunction, especially with active bleeding. Fresh frozen plasma provides clotting factors and may be used in DIC or liver failure. Monitor for allergic reactions and volume overload. Cryoprecipitate is rich in fibrinogen and clotting factors and is used for hypofibrinogenemia or ongoing bleeding. Reversal agents include vitamin K, prothrombin complex concentrate, and protamine depending on the anticoagulant and clinical situation. The third pillar is monitoring and supportive care. Reassess bleeding, mental status, and signs of thrombosis. Trend vital signs, urine output, lab values, and patient response. Watch for transfusion reactions, fever, chills, rash, hypotension, shortness of breath, or back pain. Support renal, respiratory, and neurological status. Document assessments, interventions, and responses in real time. Key monitoring cues matter. A sudden blood pressure drop may signal acute bleeding or a transfusion reaction. Decreased urine output could reflect renal hypoperfusion. Worsening confusion may indicate cerebral hypoperfusion. A new rash or fever during transfusion is a possible reaction. Stop the transfusion immediately, notify the provider, and follow protocol. Increased respiratory rate may suggest hypoxia, fluid overload, or pulmonary complications. The fourth pillar is safety and escalation. Activate rapid response or massive transfusion protocols when indicated. Communicate clearly with the team. Document all actions. If a transfusion reaction occurs, stop the transfusion immediately, maintain IV access per protocol, notify the provider and blood bank, and follow facility policy. Finally, communication. In critical care, your clinical knowledge is only as effective as your ability to communicate it clearly and quickly. SBAR stands for Situation, Background, Assessment, and Recommendation. Use it for urgent changes such as new bleeding or abnormal labs. For example, situation, the patient has new-onset bleeding. Background, recent surgery and anticoagulant use. Assessment, INR is elevated with active oozing. Recommendation, request immediate evaluation and transfusion guidance. IPASS adds introduction. It is ideal when contacting a new team member or giving a handover. For example, introduction, this is Nurse Smith from the ICU. Situation, the patient has a sudden platelet drop. Background, sepsis and recent transfusion. Assessment, oozing at the central line. Recommendation, please review labs and advise on next steps. IPASS is useful for comprehensive handovers, illness severity, patient summary, action list, situation awareness, and synthesis by receiver. For coagulopathy cases, always include current bleeding or clotting status, recent lab values, transfusions or reversal agents given, pending consults such as hematology or pharmacy, and the next steps or concerns. Escalation follows a simple pattern. Recognize the need for help, gather key information such as vital signs, labs, and interventions, communicate using SBAR to the right team member, and document the escalation and response. Know the team. The intensivist leads critical care decisions.